next to present is Dr. Hawraa Al-naqshabandi, consultant breast radiologist. Hawraa is a fellow of the Royal Australian and New Zealand College of Radiologists. Current role, she serves as a consultant breast radiologist with clinical ties to the Macquarie University Hospital in Sydney. Her expertise is focused on breast imaging, including completed breast imaging fellowship. Hawraa holds a membership of the Iraqi Australian Medical Association. The stage is yours, Hawraa.
Good afternoon, everyone, and it's a big privilege to be speaking amongst you today. Gonna start our speaking today about the Australia Breast Cancer Screening Program. We usually used to acknowledge the country and the land. I think should be already done early in the morning. So for decades, female breasts were known as the organs of beauty and femininity, and they used to keep poets busy. At some point, we have converted them into the organs of cancer, probably to keep our clinic busy and keep the business running. So breast cancer screening program in Australia is a big program, more than 30 years old, and it really helps to reduce the mortality and morbidity of breast cancer. The eligibility, I think most of you know, is female between 50 and 74 years old, and no referral needed. It is free, and they can offer all female staff, and you can do or send patient to the mammography breast screening regardless of breast density. One of the backsides of the breast cancer screening program, just like in any other thing in the world, is that it is one-size-fits-all program. And you know, you are physicians and you know all that it's hard to put one-size-fits-all program to people because, you know, people have different ethnicity, risk factors, there are different age groups and sex. So for the breast cancer, you know that there are two types of risk factors, the modifiable and the non-modifiable. I've put in the non-modifiable ones. Most of them we cannot change, like the gender, the age of the patient. But we have one non-modifiable risk factor, which is now everybody is speaking about, is the breast density. So mammographic breast density is a term used to the relative amount of dense breast tissue, the glandular tissue to the percentage of the glandular tissue to the fat. So this is an illustration of the breast density. How can I use the? Yeah, okay. So starting from here, this is the density of A or BIRAD A, which is mainly fat. This is the B, which we call the scattered, and then the C, which is the heterogeneously dense breast, and the D is the extremely dense breast. So the breast density is something that you cannot assess by examination, and you cannot determine it until you do the mammogram. So it's only definable by the mammograms. So why breast density is important, and why all the talk about breast density nowadays? Two main reasons. The first reason is, as I was saying, is that the breast density means an increase of the percentage of the glandular tissue to the fat tissue. Breast cancer usually happen in the glandular tissue. So it's simple. More glandular tissue, more risk of cancer. The other thing is that both the cancer and the dense glandular tissue appear white in mammogram. So let's have some practice here. And I will ask everybody In picture A, the fatty density breast, can you find the cancer? Is it here, 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 or here? Yeah. So good. Everybody here could find the cancer. We will repeat that practice in picture B, the scattered breast density. Is the cancer here, 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 or here? The dot one, the whitish area. And if you move further for denser breast tissue, the breast cancer gets more difficult to find and more difficult to find. So for this breast, the breast density D, even very well-trained eyes, like radiologist eyes, breast radiologist eyes, cannot find. So we are now in a dilemma. I'm telling you that there are people with high risk of a breast cancer, and I am telling you to send them for me to do mammography, and I'm telling you that I cannot, or probably cannot see the cancer. This dilemma, we have in radiology, we have a lot of substitution and a lot of other ways to solve the problem, like ultrasound. Ultrasound, sometimes when the cancer is really hard to find by mammography, ultrasound is easier to find the cancer, especially in dense breast. The other modality is the tomosynthesis. I'm not sure if everybody is hearing about it. The tomosynthesis is multi-slice mammography. So instead of one picture, we got multiple slices of the breast, just like the same principle of the CT scan. And that will help us to see the cancer in more denser breasts. And of course, the contrast enhanced mammography, where the cancer can, so we have something called subtraction. We reduce the signal from the glandular tissue, and only the enhancing cancers or enhancing lesions stay. And of course, the mammography, which the backside of the cost. The MRI, yes, is costly. Okay, so for the GP, I think this is the most important slide in my presentation for the general practitioner. This is your guideline how to manage a patient according to their breast density. People with density A and B, I think they will be easy. You will depend upon the risk of them. And then density C, even if they are high-risk people, they need to be referred to the familiar cancer service clinics. By density D, you have to discuss with them also and measure the risk and see where to refer the patient according to this Australian government guideline. How to measure the risk? These are two softwares that are defined by the Australian government, and you can use any of them. It's very simple. You can download that on your phone and measure the risk and go back to the to that list and decide the way of the management. So the breast screen program for cancer screening is still also, the compliance is only 53%. And it is a shared responsibility for all of us, everyone working in the middle field. You have to, I think we need to think again, have we done enough to help people to go and involve in the screening program, or can we do more, and what can we do more? Yeah, and of course, breast screen is the first step in the patient's breast health, but unfortunately, it is not the last step for them. Breast cancer people need a lot of cooperation. They need help from all of us, psychologists, psychiatrists, gynecologists, and they will pass through a lot, and they will need the support of all of us. I thought I will put the BIRAD slide, which is like we as breast radiologists cannot talk without saying anything about the BIRAD. So just probably take a picture of it. It's the language that we use to describe breast lesions, and it is the common language that we use with the surgeons and the clinician to understand what is the next step, the best next step for patient management. And thank you. And I will be happy to take any more questions about breast imaging and interventions anytime. Thank you.